Hello, dear colleagues. It's my pleasure today to introduce you to Manuam Vacuum Aspiration for miscarriage management and post-abortion care, and to other important issues of quality abortion care. I am an obstetrician gynecologist. I'm still working at the Department of OB-GYNs with the State Medical University in Moldova. I am also the head of Reproductive Health Training Center in Chisinau, Moldova, the NGO which has been for 20 years the most important organization in the field of sexual reproductive health rights in my country and in the region. I am the international trainer for Manuam Vacuum Aspiration for surgical abortion, but also for medical abortion, and I have conducted several trainings in my region, Russia, Georgia, Kyrgyzstan, Ukraine, but also in Mongolia, Albania, other countries in Europe and worldwide. I am the member of the FIGO Committee to Prevent and Safe Abortion, the advisor for Genuity Health Project, and the consultant for DKT Women Care Global and Women Help Women. I decided to bring you the latest WHO recommendations published in 2022, and the main recommendation, the main message is the quality abortion care is critical to achieve health for all. So the advice of WHO, what to consider quality of abortion care and how it should be effective, the care that is evidence-based, efficient, the delivery of care should optimize its use and avoids waste, should be accessible, a care that is timely, affordable, geographically reachable, provided in a setting where skills and resources are appropriate to the medical need. The care should be acceptable and should be person-centered. And what does it mean? This is the care that considers the preferences and values of service users. It should be equitable, care that does not vary in quality regardless of care seekers' gender, race, ethnicity, socioeconomic status, education, if they are living with a certain disability or based on the geographic location, and of course should be safe. A care which minimizes risks and harm. I'll follow with the other WHO recommendations or methods of uterine evacuation, and you see here that for the first trimester, up to 14 weeks of pregnancy, according to the last menstrual period, in case of surgical abortion or surgical evacuation, WHO is recommended to use vacuum aspiration, electrical mandool, and the local anesthesia with no checking curettage. I'll show you later again the WHO recommendations. And for the medical methods, it's a combination of mifepristol, misoprostol, or misoprostol alone. And for the second trimester or term of pregnancy after 12 weeks, the surgical method is dilation and evacuation, and for the medical method, it's mifepristol, misoprostol, repeated doses. The new recommendations published in 2022 on vacuum aspiration is for induced abortion at gestational ages less than 14. Pay attention, not 12, but 14. WHO recommends vacuum aspiration and recommend against the practice of dilation and sharp curettage, including sharp curette checks. What does it mean? This practice to complete the abortion with checking curettage after vacuum aspiration. And the remarks of WHO are observational studies indicate that vacuum aspiration associated with fewer complications comparing to DNC, and there is no evidence which supports the use of sharp curette following vacuum aspiration for checking the uterine cavity. Where WHO recommends to provide care in a healthcare facility, and both types of vacuum aspiration can be performed in a primary care facilities and on an outpatient basis. And talking about implementation considerations, while medical vacuum aspiration is more commonly used and more likely in primary care settings, the skills required for electrical vacuum aspiration are similar. Thus, the recommendations above apply to the provision of other forms of vacuum aspiration. MVA has certain advantages, and first of all, is used early in pregnancy and in the absence of access to a stable source of electricity. And dilation and sharp curettage DNC should be replaced with manual vacuum aspiration where it's still used. Regarding pre-abortion and the issue of RH immunization was finally solved by and proved by several studies. And the WHO recommendation, and this is very new recommendation. So RH is an immunization for abortion at gestational age less than 12. Doesn't exist, doesn't happen. Based on this, for both medical and surgical abortion at less than 12 weeks, WHO recommends against anti-D immunoglobulin administration, but they do recommend after 12 weeks. Regarding ultrasound scanning, the recommendation is for both medical and surgical abortion, WHO recommend against the use of ultrasound scanning as a prerequisite for providing abortion services. And why that? Because the legal regulation that limits the availability of abortion by gestational age may require or result in ultrasound being used for verified gestational age prior to abortion, even though this is not necessary from clinical perspective. So removing legal gestational age limits on access to abortion should result in unnecessary pre-abortion ultrasound being avoided, increase the availability of abortion in settings where ultrasound is difficult to access. Regarding antibiotic prophylaxis, WHO recommend exactly the same recommendation which was in 2012. So it says that the role of antibiotics is pertinent for surgical abortion. The presence of infection in the lower reproductive tract at the time of surgical abortion is a risk factor for post-abortion reproductive tract infections. So provision of antibiotics at the time of abortion is to prevent such complications after surgical abortion or any other intervention, surgical intervention into the uterine cavity. So the recommendation is to use antibiotic prophylaxis for surgical abortion, and you see here the list of antibiotics recommended by WHO, but this is another publication published just recently, one month ago. So a single dose administration of nitroimidazoles, tetracyclines, or penicillins has been shown to be effective when used as prophylactic antibiotic for surgical abortion. And also a very important remark, treatment regimens of antibiotics should not be given unless there is concern about an existing and proved infection. The pain management for abortion, the recommendations also is to use, should be, first of all, it should be offered routinely, absolutely to everybody. And it's, first of all, non-steroidal anti-inflammatory drugs. And the WHO recommend against the routine use of general anesthesia. And the recommendations, the new recommendation for abortion, also surgical evacuation of uterus up to 14 weeks, recommend the use of paracervical block and the combination of paracervical block with a conscious sedation, if available. Also, a very important linkage to human rights issues of abortion care. So the recommendations relevant to surgical abortion says that at gestational age less than 14 weeks, as dilation and sharp curettage, DNC, causes pain and suffering to women, and it's not recommended for use. Its use is incompatible with numerous human rights, including the right to health. This should be taken into consideration very seriously. Follow-up care or additional services after abortion. The recommendation is that following a complicated surgical abortion or medical abortion, it's not necessary to invite women to routine follow-up visit. However, information should be provided about the availability of additional services if they are needed or desired. And women, girls, and other pregnant persons must be adequately informed about symptoms of ongoing pregnancy or such symptoms as prolonged heavy bleeding or no bleeding at all, or pain not relieved by medications or fever. In these cases, women should come back and you should assess their status. Incomplete abortion. Following a complicated surgical abortion or medical abortion, WHO recommends there is no medical need for routine follow-up visit. However, information should be provided about the availability of additional services. For incomplete abortion, the management is either vacuum aspiration or medical management, and the implementation consideration of these recommendations are that the evacuation of retained products is also a signal function of basic emergency obstetric care, and training and implementation can be integrated with this basic emergency obstetric care. Initial management of hemorrhage and infection is also a signal function of basic emergency obstetric care, and training and implementation can be integrated and should be integrated with emergency obstetric care services. And the key human rights considerations relevant to non-life-threatening complications, regardless of whether abortion is legal, states are required to ensure access to post-abortion care where it is needed. And post-abortion care must be available on a confidential basis, including in situations where abortion is illegal. Post-abortion care must be available without the threat of criminal prosecution or punitive measures. And states must not require workers to report persons suspected or undertaking unlawful abortion, or require them to provide any potentially incriminating information during or as a prerequisite to receiving post-abortion care. Very important considerations. I'll give you a few important information regarding manual vacuum aspiration and why it's recommended by WHO. First of all, it's extremely safe, efficient medical technology. And when we're talking about effectiveness, we need to ask ourselves, is there are 100% effectiveness in medicine? Probably not. Safety, it means which level of complications is having manual vacuum aspiration, cost efficiency, and patient satisfaction or acceptability. And the interesting question is how to measure this. So regarding the efficacy, numerous studies show that the manual vacuum aspiration successfully empties the uterus in the first trimester of pregnancy in 99.5% of time. So in this case, failed abortion would consider the situation what we need to reaspirate the uterine cavity. And in case of manual vacuum aspiration used up to 6 weeks, and the WHO recommendations, if you remember, was to use it in early pregnancy, lead to need for aspiration just in 0.25 promille. And up to 12 weeks, the needs for reaspiration is just 0.5%, which is very, very efficient. Regarding safety, again, probably there is no medical procedure where we can say we can guarantee 100% safety, but at the same time, studies of manual vacuum aspiration show low and very low complication rates, and such as complications as hemorrhage, infection, cervical injury, or perforation. It's much lower compared to dilation and curettage. Also, local anesthesia can be used with manual vacuum aspiration, eliminating at all the risk of general anesthesia and heavy sedation. And if you remember this study, GPSA study in USA in 1975, showed clearly that time the main reason for that in termination of pregnancy before 12 weeks is the complication of general anesthesia. So less general anesthesia we're using will have less complication related to this anesthesia. In manual vacuum aspiration, we don't dilate at all or less. So we have less cervical injuries. In manual vacuum aspiration, we have less fragmentation, and it's much easier to identify the products. And also this leads to less incomplete abortion, and means again, less complications, less bleeding, less infections. Talking about cost effectiveness, the procedure costs, staff time, and other resources are significantly reduced where manual vacuum aspiration is used. It has shorter recovery time. The instrument processing is simple and cheap. And the manual vacuum aspiration does not require electricity. And you can see the publication which demonstrates this. Patient satisfaction. More than 90% of women with unwanted pregnancy would prefer manual vacuum aspiration or advise it to a relative or a friend to choose this method. It's more comfortable. Women have lower pain comparing to other methods. And why? It can be done at the local anesthesia. It can be done on outpatient base. And in this outpatient base can respect better patient confidentiality. And it's faster. It is shorter procedure time, recovery time, is silently, not noise of electrical vacuum aspiration, and also with counseling, which is recommended before manual vacuum aspiration. And the connection to other reproductive health services increases the women's satisfaction using manual vacuum aspiration. From my personal experience, and I have used manual vacuum aspiration since 2001 in Moldova and then in the region. I trained providers in the region. Why do I like so much manual vacuum aspiration? It's small and light, it's portable. I can easily take the syringe of manual vacuum aspiration and a few cannulas, which are in the sterile envelopes, to another unit if I need. We don't need electricity, and today when we have sometimes disconnection of electricity, and we are a country which is bordering to Ukraine, and the war is very nearby, we do have disconnection of electricity, so we can still use manual vacuum aspiration for this. Another fact that syringe and cannula are transparent, and during the procedure I can easily see what do you aspirate and what is passing through the cannula, through the syringe. What I appreciate also, the cannula having the dots. You can use the dots to check the size of the uterus, and you can avoid using the sonde, metallic sonde, to do the checking of uterus, the size of the uterine cavity. So you don't use the most risky medical metal instrument, the sonde, to do the checking of the size of the uterine cavity. Also, what else? The evacuated tissue can be easily examined, and this gives you the confidence that the uterus is empty, and you are sure that you will not have an incomplete abortion. Sorry. But also, if there is no gestational sac in the aspirated tissue, you can suspect on time an ectopic pregnancy and take the necessary measures. Also, I especially appreciate the fact that I can use manual vacuum aspiration under local anesthesia. This gives you the option to keep in touch with the patient, reducing her anxiety level, giving her the reassurance that everything is going well. Also, in a very busy setting, this offers the chance to see more patients. They can leave the facility immediately after aspiration and using local anesthesia. Using IVA, you can be confident the risk of heavy perforation is very small. The vacuum disappears immediately when the cannula is not in the uterus but goes deeper. And I have had such experience. A patient was having a manual vacuum aspiration procedure. In a moment, the vacuum disappeared. We suspected perforation. We stopped. Yeah, and the perforation was demonstrated. So patient was very fine, very okay, just had some time under our supervision and then left home. So this is very important, so you'll not have heavy perforation as you can have using electrical vacuum aspiration. So using manual vacuum aspiration leads to less complication generally, less perforation also, but also it's practically impossible to have a heavy perforation. Also, in my trainings, I can say that's very easy to learn manual vacuum aspiration and also to train in manual vacuum aspiration. It's much more difficult to learn how to do dilation and curettage. So during the first year of using IVA in our hospital, 1,200 procedures have been provided in the training setting. in 1 year. So immediately all the providers switch to Manuam Vacuum Aspiration instead of using the curette. I can I can show here the results of our work during the years. You can see in 2005 when we started, the majority of abortions were done by dilation and curettage, and right now we're having majority of abortion done by EVA or IVA, we see, from the total of abortions. The dots I mentioned earlier, you see the transparent cannulas, you can see the dots, and each of the cannulas has these dots. You can use them to check the size of the uterus. You don't need to use metallic instrument. The use of local anesthesia is very easy, it's very important. And here I would recommend a few tips. First, you first inject at the 12 o'clock on the face of the cervix, where you put the tenaculum. This would decrease the pain linked to the movement of the uterus during the procedure, and the women will feel comfortable. Also, the next is you inject superficially at the junction of the cervical and vaginal mucosa at 3, 5, 7, and 9 o'clock. And the most important tips for local anesthesia is please use 0.5 or 1% of lidocaine solution, not more. And please do not exceed those 200 milligrams of lidocaine, which can be dangerous. And it's very comfortable for women using local anesthesia if you give before that, for example, ibuprofen, 400 or 800 micrograms, half an hour or an hour before the procedure. And this is perfectly fine for women to resist the Manuam Vacuum Aspiration. The procedure itself is very easy. It takes very short time, maximum 2 minutes in pregnancy, up to 7, 8 weeks, maybe a little bit more in pregnancies. After 10 weeks, 10, 11, 12, you need maybe to empty the several times the syringe. But anyhow, the procedure itself is very short. It takes less time comparing to DNC. And as I said earlier, it gives you the confidence that you are using very nice and soft technology to empty the uterus and do not harm, do not destroy the endometrium, which is very, very important for future pregnancy of women. And I didn't say this, but after dilation and curettage, where I have a synechia, the most common cause of infertility in women after very aggressive dilation and curettage. And it's practically impossible in Manuam Vacuum Aspiration. So the procedure is soft, it's gentle, it removes the tissue in a couple of minutes. You can see, according to the foam which appeared in the cannula, and the fact that uterus contract around the cannula, you cannot move the cannula anymore. It gives you immediately the information that uterus is empty, and you stop the procedure on time. Do not insist and to avoid heavy bleeding after the procedure. So it gives you the very good confidence that you give to the patient very qualitative and safe care. I appreciate very much the fact that after Manuam Vacuum Aspiration, you can do the tissue exam. And as I said earlier, it gives you the confidence that uterus is completely emptied. And you see the gestational sac, you see the decidua in the aspirated tissue. The equipment is very easy, it's very light. You can find it in your kitchen, in everybody's home. So you don't need sophisticated equipment, but instead, with this very cheap and very easy to use technology, you have an excellent impact. You don't have incomplete abortions, because if you do the tissue exam, you cannot see the tissue. You just go back to the patient and reaspirate. This is very, very nice to use, and it's recommended by the WHO also to be used after each surgical abortion. What you see in the tissue examination, again, you don't use the microscope, you use just your eyes, your sight. you look for gestational sac, and very often in manual vacuum aspiration, it goes completely entire without fragmentation, and you can easily see the entire gestational sac at different gestational ages. You can see the embryo is more than 8 weeks. You can see the blood clots and the seizure, and you can easily recognize the most important, the pregnancy in the aspirated tissue. And if not, as I said earlier, you can suspect on time an ectopic pregnancy and take the necessary measures. So also it's important, please note that you need to respect the no-touch technique. You need to take the measure, do not contaminate the field. So all the precautions for infection, universal infection prevention. So you don't put for example, if you continue the procedure, you don't put the syringe which is already contaminated nearby the instruments which are sterile, and you are going to use them. So the conclusions are that with trainings and experience, providers become comfortable with the use of manual vacuum aspiration and local anesthesia. And as I said, we recognize the improvements in quality of care and decrease the possible complications. I would recommend you very much to switch from DNC, from dilation and curettage, to this more advanced technology, manual vacuum aspiration. Thank you very much.